Evening, everyone. Thank you for joining us with our program, Quality of Life During Cancer Treatment. It Makes a Difference, presented by Astera Cancer Care and with the East Brunswick Public Library and our Just for the Health of It initiative. I welcome Dr. Salwitz here tonight. Dr. James C. Salwitz is a medical oncologist and hematologist. He received his medical degree from University of Medicine and Dentistry of New Jersey, Rutgers Medical School. He then completed his residency at the McGraw Medical Center of Northwestern University in Illinois and a fellowship in oncology at the National Cancer Institute in Maryland. Tonight, this discussion topics will include treating side effects such as chemotherapy, immunotherapy, genetic therapy, radiation, as well as pain control, nutrition, exercise, and what you can do to have a quality of life during cancer treatment. I will now hand it over to Dr. Salwitz.
So good evening, everyone. Thank you so much for joining us this evening. It's an honor always to have a chance to talk to people in a little more formal, informal way than in the office on a day-to-day. So thank you very much. Topic tonight was we thought we'd talk about side effects in treatment of cancer, and how you try to handle that. Oncology is going through an incredible explosion in time. What we are curing diseases or changing diseases significantly that we never had a chance to control at all in years past. With new understandings of chemotherapy, of cancer itself, and critically of genetic therapy, molecular therapy, immune therapy, improvements in radiation therapy, we are just much better at this than we were certainly 25 years ago, but even 5 and 10 years ago. It continues to change and grow. So it's a very exciting time. And because we're achieving that much, it makes taking care of side effects, even more critical. The question it starts is, why is it even necessary to worry about side effects? Why don't we just say, hey, listen, suck it up. Let's get through this, and we'll deal with the side effects afterwards. Just get the cancer under control, do anything you have to do, and move forward. But actually, I think most people who treat this disease think the opposite is probably true, and that is the side effects are a core of success. If we're able to control side effects, or if we're able to move forward, we do that much better in curing and in controlling, the disease. In order to actually get the treatment in a reasonable period of time, you have to have the side effects, under control. And if someone is having tremendous complications and problems, etc., we just can't get the treatment done, and which means the treatment fails, or at least is limited, which goes back to my original comment. We have these great new technologies and this great success, and we can't get it done because of side effects. So actually, it's foundation, to what's going on. It also, it's also deals just with the personal toll of getting through this. It is exhausting to go through treatment and coming back and forth and back and forth and back and forth. And if we can limit that, make it a little bit easier, or a lot easier, working together, what we can do, what you can do, what families can do, that just makes it that much less exhausting getting through this, and recovering. It's always struck me as incredibly unfair that at the very time you need to make some complicated, hard, integrated decisions, you feel like crap. That's just like, you should, if you feel like crap, you should be able to go sit somewhere and heal up and feel better. But, and the reverse is true. If you have complicated decisions, you should be able to do it with a clear mind and rested and everything. But that's not the reality of this condition. Very frequently, you're feeling crummy, maybe the worst you felt ever, or at least in a long time, and you've got to make you have to make critical and important decisions. So so that makes controlling side effects that much better. It helps us set the planning expectations, telling people what is going to happen, and a lot about what's going to happen with side effects, right? The first question that we usually get or the second question is, the third is, it's, what's the disease, what's the treatment, but then very, very close right on top of what's the treatment is, what does that mean as far as side effects? So we can help people understand what those may be, and then more importantly, tell you, your family, how to deal with it. It's that much better. And then in the end, it has to do with recovering from this disease. I mean, and surviving. The cure rate is higher if side effects are controlled. The survivals are longer if side effects are controlled. So this is, really critical. And then for me, as I have on the bottom of the slide, human beings are meaning machines, by which I say is we need to find meaning in our lives. We're not AI. We're not automatons. There is a thing we need to find in every day, in every moment, some reason why we are going forward. Some of those things are the simplest things, of all. Want to get down and read the newspaper in the morning, and then go rapidly to, I'm going to spend time with my grandchildren. I want to read and learn. I want to travel. I want to play canasta. Whatever it is, I want to work and support my family. But these things give our lives meaning, and it's pretty hard to find, meaning, if you feel, really crummy. So this is a topic which we could talk about literally all day. We could write a book on this. In fact, in most of these topics, there are books written on in the individual topics. There's no way in an evening I can go through in any great detail all the different side effects there are. So we'll focus on some that are critical, the things that we think about most. But the point is there are lots, and the slide you're looking at here is it's an understatement. Now, I've divided this up into left and right, blue and green. And the reason I've done this is that the ones on the left are what patients and families are concerned about, the blue. The ones in the green are the side effects doctors are concerned about. So we're not going to talk about the doctors one tonight, because that's a lecture for another evening. But the reason I've separated these here, and you look at the ones on the right, they're different than the ones that the patient's thinking of on the left. Now, it's not that the doctor doesn't care about the ones on the left, but it's important to understand how doctors think, which is a little bit different sometimes than patients and families think. Or you might say doctors on the right, nurses to some extent on the left, or doctors on the right, palliative care people a little more on the left. I mean, doctors are interested very much in the things on the left, and we are very interested in help. But if it shows the critical need to communicate, because what the doctors are worrying about is, how is this part of the chemotherapy? The blood counts going? Are the kidneys happening? Is there any risk of infection? Is there anything, is there anything indicating that their person may be allergic to this stuff, et cetera? And most importantly, the one at the very bottom, on time, on target. Doctors are very tuned to, can we get this treatment done in the schedule it was designed to, because that's where the best data is. So I separated that just to just give you a clue to, how physicians think. It ain't that physicians don't care about the ones on the left. Clearly they do. Very much they do. But they're thinking about the ones on the right. And which makes it even more important, as we'll say, I'll probably say multiple times tonight, for you, your family, everybody to be an advocate for yourself. Because they may ask about the ones on the left, and they will, but they're thinking about the ones on the right. And that's just important. So, I mean, a critical side effect of pretty much everything in every treatment that we have is fatigue. And fatigue is a side effect of pretty much everything we do. I mean, it starts with the fact that you're worried and you're not getting any sleep. And then it moves to pretty much every illness at some point can take away energy. And then it goes to low blood counts from treatments or from the disease itself. It has to do with loss of muscle. It has to do with nutrition being erratic or borderline. The range of things that can affect fatigue is very broad, and pretty much everything that we're trying to do is some way, directly or indirectly, trying to deal with things that can affect fatigue. But as as we all know, being tired is really hard, and being tired all the time is even harder. So fatigue is an important thing, to keep in mind. And what basically there are a bunch of things that we can try to do to try to minimize fatigue. And first of all, just to correcting the medical problems and communicating with the clinicians and stuff that, saying this, I'm tired all the time. And maybe the physicians notice that your blood hemoglobin or red blood count is modestly low, but maybe the doctor's not thinking it's that low compared to being dangerous, but maybe it's enough to make you tired. So it's something that it's important to, to communicate. So maybe it's something that can be corrected. Or maybe other medical things need to be addressed, whether it's thyroid, whether, it's low-grade infections, whether it's the timing of treatments and drugs, et cetera. I mean, that's important, to communicate that because this is something that you can look at. As far as the things you can do himself, I mean, you do it individually. I mean, there's a lot of data that low level, but frequent exercise helps. I mean, basically not sitting in a corner as a cancer patient, not sitting in the bed on the sofa all day, but at least sometimes get up, walk. If you're capable of walking a decent distance, fine. But we're not talking about, this is not a time to take up, you're going to do a mini marathon. But, you're going to maybe able to walk around the block or walk around the house or walk around the living room. Just get up and move a little bit on an ongoing basis. There's a lot of, this obviously prevents other side effects, blood clots, bed sores, et cetera, but also can help, going forward. Sleep's a critical thing, and sleep's hard, and we'll actually talk again a little bit about sleep. But it's okay to take a nap. I mean, if just take that time, that can help, etc. I myself am a gigantic fan of naps, so particularly on Saturdays and Sundays. Taking a nap, it's a really helpful thing. Get a minimum amount of sleep. Just try to get the time for yourself. To get the sleep. You can. I mean, that can help. There's decent data that a light diet, can help, etc. Fruits, high quality vegetables and grains can help maintain a kind of a steady energy, a steady sugar thing. Maybe decreasing too much bulk at one time. Protein's important for a cancer patient, but on the other hand, too much bulk protein at once can kind of drag you down. Several people in this area talk about the use of light soups and everything on an ongoing basis. You're getting hydration, you get a little bit of sodium, you get some calories and protein as a way to help energy, etc., without overwhelming body. Caffeine's fine, for a cancer patient. I mean, it depends you individually if how you tolerate caffeine, or if there's other reasons you shouldn't. But there's nothing wrong with caffeine. Caffeine does not stimulate cancer. In fact, caffeine probably help protect the liver from certain things, and that's fine. On the reverse from the napping, sleeping part is don't drive yourself into the ground. Try to get more time, etc. And this goes back to families and people working together, just trying to get time so that you don't have to overdo. Don't work yourself to over fatigue, etc. Pace yourself on an ongoing basis. Depression and fatigue have a lot to do with each other. As I put this, it's a negative loop. You get a little depressed, which means you do get a little fatigue, which means you don't do more, which means you get a little more depressed, fatigue, etc. I mean, this has a lot to do with support systems, has a lot to do with formal treatment of depression, which your care team should be able to help you with. And obviously has a lot to do with families and support and stuff, and that can make things work. And in the end, there are medications that we do use for fatigue. I mean, simple things, just making your thyroid's okay, but that's the easiest, stuff. We do use stimulants at sometimes. Medications like Ritalin can help people just be a little more awake. We use, some low dose steroids for this, etc. And there's keeping energy going, or keeping you going, etc. And then again, it's a little bit of a positive loop that if you have a little more energy, that you get a little more done, a little less energy, etc., and it cuts down fatigue. I think every cancer patient that hears the word cancer, thinks about pain. Pain is something we are much better at treating than we were. I think the idea of a cancer patient that is completely out of control pain is something that we're better and better at eliminating. We have such a wide range of different techniques and technologies to control pain. We don't want you to tough it out. We do want to understand what's happening as far as pain. Nobody ever got over pain just by, this type, just by being a martyr. So there are there's multiple different types of pain. And this time I say types of pain, I'm not talking about emotional pain. I'm not understating, I'm talking about physical pain. But there's a pain that's acute. I mean, it's now something has just happened and we should be fixing it, getting under control. And that's sometimes a little easier to focus on because I have this pain, it's going to get fixed and then I'll move on. And there's chronic pain. That's an ongoing injury or pain, et cetera, which, requires long-term, pain care. Of course, the first goal of pain control is, fixing whatever the problem is. If that's a damage to a bone, whether the bone needs repair, whether it needs radiation therapy, whether or not you need some injection in the area. I mean, that can be a physical thing that can be fixed if it's an infection that needs to be brought under control. And trying to handle the problem. But nonetheless, despite our best techniques to handle those things, I mean, there are pains that are harder to control. With those simple kind of things. In which case, we used to move into medications. Now, I put it at the bottom, but I'll get to it just immediately. Addiction in cancer patients, or more broadly, addiction in people taking medication for pain is really not a significant problem. I mean, where you get into trouble with condition is when you're taking pain, pain or narcotics for specifically as a sedative or specifically sleep. Not that you're having pain that keeps you awake, but you're not having pain, you just take a narcotic to knock you out. And that's the slippery slope, where we get addiction. But for pain medication, in the cancer patient, addiction is not a gigantic problem. We often, though, however, start with anti-inflammatories, whether it's drugs like Motrin or Naproxen, but we also use steroids in this context, which is a strong anti-inflammatory and can be tremendously beneficial. Steroids have more side effects that continue for a long time, but for a modest period of time, the people who tolerate them well can really help. And then you get into using narcotics. I mean, when we target narcotics, the proper long-term for chronic pain narcotic use is a short-acting narcotic, something that you take now because I'm having pain now, and it works in a few minutes and then wears off in a couple hours. And on top of that, some sort of a time-release pain narcotic, something that you take once or twice a day, or you have a patch or something, and that's continuously released. So you use the continuous narcotic as your platform, and then you add a pain medication extra on top of that if you need that. And that's a combination you use, and you adjust each dose close slowly over time. Again, these are very valuable medications. This is where they can do remarkable goods. And the thing about getting your pain under control is it lets you get back to life in general. It gets back to my whole foundation of why quality of life during cancer care is so important. So you get out, you get moving, you can do walking, which means you can exercise, get going. So these drugs are very, very helpful. Anyone that's worked with me knows that I'm a gigantic fan of medical marijuana, MMP. I just think, it's, as a higher statement, I think marijuana kind of deals with many pieces of the cancer journey, whether it's pain or fatigue or sleep or anxiety or nausea. I mean, I think it's very beneficial, and you can add it to other pain medications. This stuff can be very, beneficial in multiple forms. And then radiation is used as a tool to treat specific area, particularly from cancer that are causing pain. I think the other thing, another major topic everyone thinks of when you start thinking about cancer, is cancer care as being nauseous. We are infinitely better about controlling nausea and vomiting with chemotherapy than we used to. I actually, remember a time when I was at the NIH in the 80s, when we had chemotherapy and some real strong chemotherapy drugs, and we had like no anti-nausea medicines. And everybody getting cancer therapy had to go in the hospital because that's what you did. You get the treatment, you'd be sick for a few days and really sick. And so we're at the other extreme now. The vast majority of patients who are getting ongoing therapy are not having ongoing nausea and vomiting. And if they start to, et cetera, we're able to adjust it and change, et cetera. So, I mean, people do so much better, because the baseline, the medications that we use. And it gets kind of, it is a general statement, not a universal statement, but a general statement, chemotherapy gets a little better as you go along because we learn your tricks with who has nausea, who has constipation, et cetera, and we can make adjustments. So we have really good medications, including marijuana, I know at the bottom, for that. As far as what, but there's still some treatments, some diseases, that over time you still have some problem with nausea and diet and everything. So, I mean, there are some good clues to that. I mean, first of all, you don't eat, the most of us, eat, 1 or 2 big meals a day. maybe a little at other times. And that's a bad idea. If you're living in this particular world, you're dealing with a fragile stomach or nausea, etc. Eat small meals, snack, don't binge. A little bit through the day. And you can build up, a reasonable, excellent nutrition by doing that, in a kind of ongoing way. And that can really help. You actually can help nausea by staying hydrated. You get dehydrated, you start to get a little weaker and stuff, and you actually get more fatigued and nauseous. So, trying to get clear liquid, 60, 70 ounces of fluid down a day, whatever that liquid is, whether it's Gatorade, whether it's juice, whether it's soda, try to limit the amount of tequila maybe. It's that's a good way. And just as speaking as a caregiver, something we do all the time is we tell patients, listen, you're getting dehydrated call us, come into the office, and we can give you an IV fluid for an hour and send you on your way. And that can sometimes just get people over the hump, particularly if people have had chemotherapy in the last few days, et cetera. That can just kind of flush their system out and everything. But other patients too. As far as foods, play with flavors, because a lot of times flavors have been changed by a lot of our drugs and treatments and stuff, and things that used to taste good to you just taste not at all, or they even can taste foul. Try charred foods, just as lemons. Some people say pickles and stuff. Do that. Add ginger root to flavor foods. You also get sliced ginger, candied. You can use a little bit of a stir fry and stuff that can really help bring out flavors, etc. As far as drinks, flat drinks, not soda, soda. A lot of people will tolerate colder foods better than hot foods. Now, as some of you know, there are several chemotherapy drugs that will tell you not to eat real cold stuff with, but most times, that's so fine. And then avoid the foods that you would normally add, just to give you some spice to life. Things that are heavy, greasy, spicy. They're not likely to to deal with you well. And then then the foods like Ensure, milkshakes or smoothies and stuff, they're a good idea. Trying to get a balanced diet. You need protein. Cancer patients' bodies are rebuilding and growing and repairing. So that's important. But again, I said earlier, not all at once, not heavy. Cancer patients constantly ask about, what about sugar? Sugar feeds, cancer. And I think, the data that makes a big difference as far as cancer care, and I think is small. But I think it's a good idea to stay away from concentrated sugars anyway, because of the variation in sugars and healing and repair, et cetera. So I do recommend people, you can have a piece of candy, some ice cream occasionally, et cetera, but not a lot. Most oncologists don't believe in over-the-counter vitamins. Obviously, if you have a nutritional deficit and we detect that, we'll replace that. But, I think the basic theory, is that, the body thinks that, the vitamins look like an apple and the balance of them, they don't think it looks like a pill, and the artificial balance of high levels of vitamins is probably not a good idea. And there's actually some data that says may actually inactivate certain cancer therapists. And there's nothing wrong with sitting down with a nutritionist and getting their idea. These people are professionals that know a lot about it, a lot more than I. Hair loss, it's a real common side effect. I got nothing here. We use cold caps sometimes. Cold caps have some benefit, and there's this cap that pumps cold liquid through your scalp while you're in the office getting the chemotherapy. The idea is you're protecting the scalp, and it's some success, but it can only be used in certain defined short-term therapies for a modest period of time with some success. For most patients, is not a lot of success. And there's no real medication, everything that's going to help. All I can tell you is the hair always comes back. It does. And there are many of our therapies, the immunotherapy stuff, that don't cause, hair loss. Shortness of breath. I put this over here. This is actually a side effect on the other side, but I'd put it here just as if you get short of breath, your clinicians need to know about it. All right. This is not a normal side effect of treatment. There's something happening. You're anemic. You got an infection, God forbid you got a blood clot. These are all fixable things. But if you get a shortness of breath, Now, on the other hand, if you're ongoing shortness of breath that limits your performance, and you work with a clinician to find that things is optimal, then this may respond, this can respond to physical therapy, small amounts of, exercise, sometimes steroids, everything. It can open up breathing, and sometimes, oxygen can be of help, etc. But if this is a significant change, somebody needs to know about it. I think we all go insane when we can't sleep. And it goes back to my original comment earlier. I mean, how if you can't if you're not rested, if you can't function, if you can't focus, you can't deal with the complexities of the things that are going on. So sleep is incredibly important, and boy, do we screw up sleep. A lot of chemotherapy drugs and stuff, interfere with sleep cycling. Sleep cycling. If you're taking steroids, they may keep you awake. If you're taking other medications, they may knock you out during the day and you can't sleep at night, etc. And it's a big problem. And it can debilitate, your ability to function, going, forward. So there are many causes of this, but it's in all these different areas, but it's very important not to mention just the baseline anxiety of dealing with this scary disease. But this is important that we address it. I mean, this is not something, tough to do. So first of all, as a baseline, try to use good sleep mechanics. And by good sleep mechanics, I mean, only one thing happens in bed, putting sex aside. One thing happens in bed, and that sleep is what happens in bed. You don't read in bed. You don't look at your iPad in bed. You don't stare at the ceiling in bed. You go to bed, turn the lights off, etc., and you go to bed. And if you're not asleep in a relatively short period of time, most experts in this range, the number they use is 20 minutes or so, and get up and do something else and come back a little bit later and go to sleep. Stay away from cell phone, iPad, etc., for for at least half an hour, maybe an hour before you go to bed. Try to go to sleep at in bed at the same time. And if in the middle of the night you wake up, it's 2 o'clock, 3 o'clock in the morning, and you wake up and you're not going right back to sleep, then get up, go do something, come back, not watch TV, not go on your iPad, go back to bed and stuff. Then it will may help the difference to get you in the habit of sleeping in bed. And as I said earlier, naps are okay. Controlling the other symptoms are okay, whether it's pain or whether it's nausea, or whatever it is. And then again, you may need help your clinicians to help identify, and deal with those symptoms. Melatonin for many people, is a benefit. Don't forget, melatonin is not a sleep drug. It is a sleep cycling drug. In theory, our bodies make melatonin as the sun goes down, and it tells our body to go to sleep an hour or two later, which means if you want to go to bed at 10, take your melatonin sometime between 8 and 9 and the 8 and 9. So it starts cycling and telling your body, to go into bed. A lot of sleep medications out there. Depending on the individual, they can be of significant benefit, or not. Sleep medications only work for 4 hours. The stronger things like Ativan and stuff, if you're just waking up the next morning and you're still kind of stoned from the sleep medicine, that's not a good medicine for you. It's one of the reasons, people don't like Ativan as a sleep medication. It's just too long acting. But you can work with that, see if that helps, etc. And somehow I've got marijuana in this too. I should be selling it. But again, this is a very important, thing, to deal with all of what's, going on here. Rashes are a really common thing around cancer therapy. You're part of that, other than explaining to your clinicians that you have a rash, is make sure your skin is not too dry. Don't using too harsh soaps or using too hot a shower. Use a skin cream or an emollient stuff, etc. If you think your skin's getting dry, try to protect your skin and stuff. And then same thing in the summer. Watch out for sun. Many of our drugs are sun sensitizing, and you want to wear a good sunblock. We're like 50 or so, and just be careful as far as that. Wear loose fitting clothing so you don't have chafing, etc. And you have a rash, and let us know, because we have a lot of things to treat it with. And the reverse is, a lot of our medicines and stuff can cause rashes in some individuals, and and we need to know what's going on. The last, comment is the loss, which is activities of daily living, and which is basically a statement that all of this stuff kind of gangs up on you, and you can't do as much, as you want to do, and that is a gigantic side effect, which kind of gets us in, to this next topic. So I kind of separated this one out. I said, these are the things that our lives more in general. They're more the personal side of stuff. I mean, obviously it all overlaps, etc. But I was kind of seeing these a little bit different, because these are side effects of the disease. These are side effects of our care, right? So if, so if I say to you, I mean, listen, you're going to be having chemotherapy, every week for, a year, I mean, suddenly your job's in trouble. And your ability to work, or you're just going to be so wiped out, you need to step away. And that will have financial, consequences, potentially. And these are things that we as clinicians need to help you deal with, but also you to give supports. I mean, so like this is, palliative care can be a support to this. Our financial people can be of support to this. And plus, your financial, advisors and stuff, whether you're working with an accountant or a banker or whoever it is, try to deal with this. And then also from the employment standpoint, as we can work with you to either work, and modify your job as much as, to work, et cetera, or deal with getting unemployment, et cetera. I mean, these things have to be handled in an aggressive manner, because these are clearly, side effects that, really change, your life, et cetera. And, we're willing to be involved. You need to be involved, et cetera, and think of these things in a practical, aggressive manner. So, sex is really important, for us as human beings, and how we deal with life and how we find intimacy, and how we see the world around us. As a general, and a lot of the stuff we do affects, it affects sex directly and indirectly. Indirectly, it's because I'm sick, I have cancer, I'm scared, I don't feel intimate, I don't feel sexual, or the reverse. I don't feel as if I am sexually attractive, as if someone would want to be near me, and would want to touch me. And this becomes a real problem for individuals and for couples. And so it's an important topic to discuss. And I mean, first, a general statement: sex is generally safe for a cancer patient. I mean, it's they're not. Our drugs are not somehow wildly contagious, et cetera. My third comment is that if you've just had chemotherapy in the last 24 to 48 hours, most people would wear some sort of protective, a device and stuff, because semen may have chemotherapy in it or something, et cetera. In microscopic, tiny little amounts that probably don't account to anything, but it's a common sort of, advice. But, sex, you can be intimate, you can be with someone else. You are still a sexual being, both in your needs and in the needs, of your partner. And this is something that can continue. A general statement is something that needs to be approached gently, slowly, carefully, thinking more about intimacy itself, being touching and holding and being together in a gentle, sharing way, as opposed to intercourse itself or whatever sexual release you're using, et cetera. And on the other hand, it may require, thinking, modifying, positions, modifying methods, and just taking the time to do so and being careful and being honest with your partner about, I have this has happened to my body. I feel as if, I'm not attractive anymore. And I've talked to a lot of cancer patients and their families and stuff, and that's essentially almost never true. People that want to be with each other, love each other, want to share with each other, they want this time, but you have to, share that. And then also, talk to the physician about it. If you're not comfortable talking to the physician about it, talk to the nurse about it. Not talk to the palliative care person about it, et cetera. If there's something the information you need, or if there's something you help as far as medications, et cetera. But you're still sexual being. And that's just, that's what we are. And it's important to feel comfortable in sharing that going forward. If nothing else, just, the time just, of being together in a more healthy, normal manner. You can lump together next to right together loneliness and fragmentation, et cetera. I mean, this is a terrible emotional disease that affects everyone on a continuous basis. And people feel alone and isolated often, even when they're not, and even when their family is right there. And it goes back to the comment I said before. I mean, it's a time to try to be honest with your family, to share, to listen to each other. If you're the caregiver, to understand that that's happening to both of you, because it's happened to the caregiver too, and to communicate, back and forth, to prevent as much as possible, the fragmentation away from family and friends and community. We have some tendency when these things happen to us to kind of isolate ourselves. And that's okay for a while here and there as we need to heal. But let's not forget we're social beings and we need to be able to be with each other, et cetera. And as family of a loved one who's sick, and we have to remember that they need us there, and maybe they're not in a pleasant mood all the time. But they need us there. And as someone who is suffering and stuff, sharing that time, reaching out, making connections, maintaining those connections, is important as far as that. The next two are really the same thing, and one and the other, and that is, your body has changed, and this is a side effect of cancer and cancer treatment and etc. And understanding what that new body is tough. It requires time. It requires experimentation in the sense of what can I do, how I do, etc. It's really hard. The global experience is it gets better. You do adjust over time, but when you're sitting on one side of it, and this first happens, it looks like this mountain up there. It's not going to get better. But again, and this again has to do with talking to family, talking to nurses, talking to palliative care, talking to your doctor, etc. What does this mean? How does it happen? What are capable of? And it requires some experimentation. And that's very similar to the next, what are concerned about, what are we going to look like going forward? And then it has to do with, again, communicating and listening. And then, of course, fear of dying. The elephant in the room every single time. We do very well against this disease, but we don't always cure it. And it's, it's important as much as possible because this is what you're feeling. Everyone is feeling. I'm going to talk about it, to talk about it, understand what is the possibility, what can happen. Clinicians are notoriously bad about figuring out timeframes, but people can talk about prognosis. And experience is that the more you talk, the more you share, the better you can deal with this terrible fear that we all deal with in dealing with disease. The last comment here is just that, it goes back to the original comment. You're dealing with all these side effects and so much is happening, and you just can simply sort of feel kind of out of control. And that's a matter of time, and pacing yourself and communicating and listening and just trying to deal with it step by step, by slow step by slow step. And it's, you have a lot of people around to help and, get you through this. So, these are kind of concepts that I think help people kind of, deal with this, so, move, that moves, there we go. The first is, write your concerns down before you come to the office. Lists are very important. I had a patient to come in today, and she said, you think I'm ever going to come in here without a list? And frankly, I hope not. I mean, because even that list is to tell me what she's doing for, her kid's birthday party. Lists are very important. When you walk in the office, it says overwhelming place. And, and then, like I said, clinicians are concerned about the one list, and you have your own separate list. Write things down, and if you can, write down the answers, because it's hard to listen. Now, I prefer, that you have someone with you, which is the one below, and that is, this is a team sport. This is a very hard thing to do by yourselves. And there are certain times that patients just get stuck doing this by themselves, and it's just even harder. So if you can bring someone, a family member, a friend, just someone who is willing to advocate for you, just because they have another set of ears there, et cetera. I mean, that's a really important thing. And then when you're on the team on your treatment side, it's not just the doctor, right? It's the nurses who have a tremendous experience, in this. It can be the front desk. It's the person that maybe puts you in the room, et cetera. It's who's mixing the medications, or the pharmaceutical people. It's people from finance. In our finance group, it's incredibly strong. Our finance group arranged for $15 million in donated drug last year for our patients. So I mean, it's talk to these people. And then there's the whole concept of palliative care. Palliative care ain't hospice. they share a boundary, but they're not. Palliative care is dealing with side effects of treatment, all the above. And it's not end of life. It is how to live through life. And many of our patients who are seeing their palliative care people are cured. So, I mean, don't hesitate to reach out and get that kind of support. You can put in the upper right, et cetera. And, it just a thing that the data says this happens more than the doctor thinks. And that is, it says, and I say, you can't comply, say why. If someone is designing a therapy for you and at your gut level, ain't gonna happen. I'm not gonna take that medicine. I'm not gonna do this, etc. Fantastic. You have to pick your path. Our job is to support you on that path. Say it. Let someone know that you're not. This is just not going to work, and we'll deal with that. It's not our job to tell you what to do. It's our job to give you suggestions, guidance on the path, etc., on the possibilities. And if you can't do something, etc., I mean, this can range from that's a drug I will just not going to take, I just can't tolerate, to, I'm going to be at my kids', graduation in May, period. Now, how are you going to deal with that? And that's our job. And then any clinician that cares about you is going to support you in getting a second opinion. This ain't about us. This is about you and your health and your family, etc. So don't hesitate to say, listen, can I get a second opinion? Most clinicians, they really should. All clinicians should help you get that second opinion. You shouldn't have to arrange yourself and then sneak around behind. Nobody's feelings should be hurt. This isn't about our feelings. This is about finding your path and health, etc. So, big fan of, getting second opinions. As I said, the worst thing that happened in second opinion is that we all learn something. So this is about control. This is about you and us working together so that you keep as much as your life normal as possible. You are a warrior. And the object is not to be a cancer patient in a corner somewhere suffering through this. It's to be as active, it's social, and control. The goal is to continue to live your life. And that's important just for living your life. And it's incredibly important for being cured, for moving forward, to recovering, to, dealing with this period of time. And an aggressive approach by all of us to dealing with these side effects, et cetera, is incredibly important. And it's how we move forward. So thank you very much, for spending the time with us this evening. I hope this is some value. And thank you so much.
Thank you, Dr. Salwitz. Okay, so we can have everyone begin entering their questions in the chat. I did see a couple already. So we'll start with the first one. Someone asked between tamoxifen and, I'm not sure if that's an abbreviation. Actually, let's have that clarified. Hold on.
Is that like as I say, the AI or an
Yeah,
Astera?
like AI.
Yeah, right.
So AI,
It's
which
not
ones
artificial
are,
intelligence now.
thank you. Which ones are stronger, better in treatment of triple positive breast cancer post chemo, radiation / mastectomy? And they thank you very much for your answer.
So the AI aromatase inhibitors or tamoxifen, these are both medications that block the effect of estrogen on breast to help breast cancer cells grow. So classically, tamoxifen was given to premenopausal women, and AIs were given to postmenopausal women. However, we do know that AIs are slightly better, slightly more effective than tamoxifen. So if we have a high-risk patient, like you just described, pretty much, you have a high-risk patient who is premenopausal, we will often make them chemically postmenopausal with another medication so they can use an AI. They have similar but not identical side effects. And so in a average risk premenopausal woman will use tamoxifen, but in an increased risk premenopausal woman will use medication to make them chemically postmenopausal while they're taking the medicine. In every postmenopausal woman, we would use an AI.
Okay, and the next question is, what do you think about sleep and pain CBD?
So the problem with CBD, the answer is the problem with CBD is it's completely unmeasured, unregulated, and incredibly variable. I mean, CBD is from flax. It's not from marijuana. It doesn't have any THC in it. So it depends on the product and on the individual. I've had patients say that, available CBD helps them great with sleep. I should say was completely didn't work at all. If I have a choice for someone as a sleep, product of that type, I would have somebody just use cannabis, either, as a gummy or as a vape.
Okay. Next question is, with low white blood cells, can you still go to the theater if you wear a mask and avoid people?
So when your white blood count low, depending on how low it is, increases your risk of infection. Most of the infections you catch with low white blood count are actually from yourself. You catch from your own skin, your own gut, your intestines, flora, etc. That's where those infections come from. For most people with a low white blood count. If a white blood count is extremely low, by which I mean, significantly less than 1,000, it may not be the brightest thing in the world. It probably doesn't make a big difference, but it's, probably not perfect. If your white blood count's above 1,000, etc., I think going to the theater, as long I wouldn't be, giving smoochy hugs to everybody around, but it's probably okay to do. And then don't forget, most of these things are not transmitted by droplets or air; they're transmitted by touch. So a little Purell, a little hand washing, even in the theater can go a long way. My wife has this habit of getting on airplanes or any place we sit down that she wipes down all the chairs and the tables around us and everything like that, which is annoying. We're getting an airplane for everyone else around them, but touch, don't forget, this stuff is generally transmitted by touch.
Okay, thank you. And let's see if we get another question. In the meantime, I do see that people are thanking you in the chat as well. Great presentation. Thank you for your time. Does anyone else have a question that they would like to enter in the chat? We'll hold on and wait for those. I know sometimes it just takes time while you're typing. Don't see any other questions yet. In any case, I really want to thank you, Dr. Salwitz, for your very informative presentation. We definitely like to have Astera Cancer Care give as many presentations as possible with the East Brunswick Public Library. Usually we try to have that every month or every other month, so everyone should always be checking our calendar if you want to attend more of our programs, whether it's with Astera Cancer Care, any other topics that we cover here with the Just for the Health of It initiative. But it looks like no one else has a question. Oh, here's another one. Okay. Do the amount of days to feel bone ache after Neulasta vary with age? Does that vary with age? And it used to be
Was it
2 days only before for
was it
their.
vary with age, she said, the question?
Yes, it's a little roughly written. So let me see.
I mean, I guess I get the concept.
Does it vary with age, the amount of days that you feel bone ache after taking Neulasta?
Huh. So Neulasta is a medication that's given by injection after chemotherapies that can bring down your white count. Neulasta stimulates the bone marrow to make white blood cells. Unfortunately, you're stimulating cells to suddenly grow very quickly inside the bones, which there's no place for the bone to spread. So you increase pressure. And it can cause, in many patients, extremely intense lower back pain. Sometimes also in legs and arms a little bit, but generally lower back pain, which is extraordinarily, remarkably uncomfortable. It generally starts about 2 days after the injection of Neulasta, some a little earlier, some a little later. It's prevented a little bit by Claritin, the antihistamine Claritin, as strange as that is, it does. And with some patients, it's uncomfortable enough that they have to take pain medications. I have never heard the observation that it could change with age. That's actually an interesting concept. I'll have to give it some thought. I mean, I guess it might make sense that it would take a little longer to happen with someone that's, a little older, because they have actually less bone marrow. As we get older, our bone marrow shrink down from our bones, end up in our pelvis, so they have less bone marrow in their back. So I think a younger person might be more sensitive, and there is timing, it might start earlier, but I've not given that thought or observation before.
How useful is blood work for circulating tumor cells?
So the future of oncology diagnosis and treatment is going to rely heavily on looking in a blood test, destroying blood, looking for either fragments of cancer cells that have broken down or actually circulating tumor cells itself. The first is much more common, the so-called liquid biopsy. And it's not a long time before all of us that we will go to our doctor, and in addition to checking our cholesterol, they will do a liquid biopsy for cancer, which in theory we'll be able to find almost any cancer, because of the fragments of genes in the blood that we found. And we're using this technique more and more now in patients we know of cancer. So if someone has a lung cancer and you look in their blood and you can find the gene floating around their blood, then we can use that to track whether or not the cancer, the cancer therapy is working. At this point, because it's a unproven therapy as a way to monitor and diagnose, as a prevention. None of us would do this yet because it is too high a false negative, false positive rate at this point. If we have a patient now that we are able to make a connection of that kind of a test to a cancer, et cetera, it's a reasonable way to monitor, and we do look for this now in patients, in looking for now as a way to monitoring our treatment, going forward. And then not long from now, it'll be something we just do. And it'll be this, and this is soon. And this is the way we'll look to screen for cancers. Right now, no one knows, what you would do with the information, what tests you would have, or how often you're going to miss something, and just reassure people falsely.
How effective is proton therapy for prostate cancer?
So proton therapy is a ultra-targeted radiation treatment that has the ability to radiate, the front of your eye without radiating any radiation to the back of the eye. It's incredibly accurate, with millimeter precision. It's very powerful. It works very well. It's useful for anything you want to radiate that you can define well where the cancer is, and therefore you can use something this accurate. Regular radiation spreads out a little bit, so you get edges and margins around it. So it doesn't have to be it's accurate, but doesn't have to be perfect. A proton, is nearly perfect. But the answer is for a disease like prostate cancer, it can be very effective. If you're able to define, the therapy, the tumor, that. So it's one of the radiation tools that can definitely be used in not every patient with prostate cancer, depends on the person, but if you can, define that, then it can be very effective.
So that's the end of our time. Thank you everyone for joining us. Thank you, Dr. Salwitz, again for joining us and making this possible. And then we'll see each other again soon, hopefully another program.
Well, thank you so much, and we appreciate the Spread Library doing this. It's a tremendous community service. Really is.
Thank you. Thank you so much. All right, everyone, have a good night.
Take care.